Hi, I'm going to present a talk on diagnosis of extrapulmonary tuberculosis cases by GeneXpert MTB RIF Ultra method. I am from Microbiology Department, Faculty of Allied Health Sciences, STT University, Gurugram, India. Although pulmonary tuberculosis is the most common archetype of tuberculosis, extrapulmonary tuberculosis is a serious concern that accounts for 15 to 20% of the TB cases and constitute up to 50% of TB in HIV co-infected individuals. Diagnosis of extrapulmonary TB is difficult, predominantly owing to various anatomical locations, atypical clinical presentation, and paucibacillary nature of clinical specimens. An early detection of extrapulmonary TB and drug resistance is crucial for the initiation of anti-tubercular therapy so as to prevent morbidity and mortality. Extrapulmonary TB diagnosis mainly relies on clinical features, bacteriological examination, imaging, histopath examination, and nucleic acid amplification test. Those smear culture and GeneXpert as well as GeneXpert Ultra are considered for definite diagnosis of this disease. The conventional PCR using IS6110 or MPT64 target is not being used for extrapulmonary TB diagnosis, albeit PCR along with clinical feature is considered good as positive test. For the same, coming to GeneXpert and GeneXpert Ultra. GeneXpert Ultra is a modified version of GeneXpert. First, let's talk about GeneXpert Assay. It's a major innovation for simultaneous detection of MTB and RIF resistance targeting RPOB gene of MTB, where RIF resistance represents a surrogate marker to evaluate the MDR-TB as it reveals the presence of more than 90% of INH resistance. Moreover, 95 to 98% RIF resistance clinical isolates have mutation in the 81 base pair RIF resistance determining regions of RPOB gene of MTB. In 2017, the WHO endorsed a next generation expert, that is GeneXpert MTB RIF Ultra, on the GeneXpert platform only to improve the technology and sensitivity of GeneXpert, including rifampicin resistance. GeneXpert Ultra is a fully nested real-time PCR targeting IS6110, IS1081 and RPOB genes, which is being utilized for detecting MTB and RIF resistance within 80 minutes. Ultra uses 4 sloppy molecular beacon probes that target the RIF resistance determining regions to detect RIF resistance, 2 additional probes including a Tapman probe targeting the multi-copy insertion sequence 6110 and a molecular probe that target the multi-copy insertion sequence 1081 are also being used. The Expert Ultra results are semi-quantitatively detected as high, low, very low, trace call and not detected categories. Both Expert and Ultra can run in the same instrument after a software upgradation. Ultra exhibits better sensitivity than its predecessor Expert in most of the extrapulmonary TB specimens, but at the compensation of specificity values. Among different EPTB types, Ultra has performed well in TB lymphadenitis, pleural TB and TB meningitis, though limited information is available on other EPTB types. We also detail the other molecular tests in this study for detecting MTB and drug resistance, including the RIF resistance. Those methods include line probe assay, TrueNAT, TrueNAT Plus, and TrueNAT RIF test, as well as the whole genome sequence, where real-time PCR and loop-mediated isothermal amplification test, immuno-PCR, and nano-based immuno-PCR, they detect only MTB only. Coming over to the assay chemistry of this assay, Ultra has 2 new PCR assays compared with Expert that target IS6110 and IS1081 gene. Then conversion of RPOB and this IS 6110 and IS 1081 assay into fully nested PCR, while the GeneXpert has semi-nested PCR. Then introduction of new trace call in addition to semi-quantitative categories high, medium, low and very low reported by an expert. The use of a larger PCR chamber in Expert Ultra, which comprise 50 microliters, that double the amount of some sample DNA compared with Expert. Ultra reveals an LOD of 11.8 to 15.6 CFU per ml for MTB in spiked sputum sample, which showed an 8-fold improvement over Expert. However, Ultra exhibited a bit higher LOD compared to culture on both MG80, 916 and non-Janssen media, but it has a much shorter turnaround time of just 80 minutes as compared to culture, which take 2 weeks for MG8, 96, 960 and 4 weeks on non-Janssen media. Meanwhile, if resistance is detected by analyzing the molecular probe melting curves. Further, real-time PCR signal obtained during the second nested amplification in Expert Ultra indicate presence or absence of MTB, and that is followed by the TM analysis. TM value is thus generated by by RPOB. Sloppy molecular beacon probes are employed to detect whether the wild type or mutant rifampicin resistance determining region DNA sequence. Additionally, Ultra effectively differentiate the silent mutation, the mutation in the mixed infection, and reveals the diminished false positive RIF resistance as compared to the expert. This shows the workflow of this Expert Ultra. In this, the clinical samples, they are mixed in 1 to 2 ratios, which contain the commercial sodium hydroxide and isopropanol. After thorough mixing for few seconds, the mixture is, incubated at room temperature for 15 minutes, and then it is dispensed into the process samples into the Expert Ultra cartridge, and this cartridge is then inserted into the Expert Ultra machine as per manufacturer. Then coming to the interpretation of the results, there are two, control over here, PCC and SPC, which means the probe check control and the sample processing control, so that the probes and reagents are working well in the real-time nested PCR of the Expert Ultra. Here, we used, IS 6110 and IS 1081, and in presence of these signals plus more than two RPOBs, sloppy molecular beacon signal, the assay is triggered to post PCR melt stage, and based on the CT values and TM values, the results are semi-quantitatively grouped as high, medium, low, very low trace, as well as not detected, as well as RIF resistance positive or RIF resistance negative. However, in this case, when there is less than 4 RPOB sloppy molecular probes, they generate their TM values. The result is changed to RIF indeterminate. The separation of Expert Ultra into real-time amplification and post-PCR melt stage, it permits the detection of MTB negative and trace calls within 60 minutes and RIF detection within 80 minutes. Interpretation of trace calls should be done carefully in Expert Ultra, especially in HIV-TB co-infected individuals, patients with the positive TB history, or those on ATT follow-up, and whether the individuals suffer from childhood or adult TB. However, other parameters, that is clinical presentation, detailed imaging comprising ultrasound, CT scan, MRI, etc., and histopathological examination need to be considered to confirm the extrapulmonary TB diagnosis in individuals with trace calls. As per the WHO recommendations, trace calls are interpreted as among people living with HIV children and APTB cases, trace call should be considered as true positive for clinical decision and ATT follow-up. For HIV negative patient with trace result, the recent past history need to be considered for initiating anti-tubercular therapy. Further, individuals who have initial positive trace call, a fresh specimen should go a repeated test and the second report can be used for clinical decisions. However, clinical and radiological findings should always be considered for the definite diagnosis. This slide shows the comparison of diagnostic yield of expert ultra versus expert in different extrapulmonary TB types, and there are several studies which mainly include here TB lymphadenitis, pleural TB, and TB meningitis. I will give an example. I have highlighted it in red colors. Using lymph node biopsies in the first lane, there is a sensitivity of 91%, specificity of 76%, while with expert, the sensitivity is lesser, it is 72%, while the specificity is more, 93%. So coming to the third lane, the ultra shows the sensitivity in TB lymphadenitis with FNA, fine needle aspirate biopsies, show the sensitivity of 81% and specificity of 90%. Similarly, expert shows the sensitivity of 71.4, which is lesser, while a higher specificity is seen here, 100%. Similarly, in pleural TB cases, here it shows like using the pleural fluid, we have a sensitivity of 37.5, specificity of 98.8, while the sensitivity goes down with expert during the head-to-head comparison using the same specimen, it is at 28.6, though the specificity remains the same, 98.6. Then again, coming to the pleural fluids specimen, the sensitivity is 75, specificity is 87%, while with expert it is 49.5% sensitivity, while the specificity goes higher, it is 98.9. Overall, what I want to convey is the sensitivity is always mostly more with the expert ultra in these extrapulmonary EPTB types, while the specificity either remains the same in both the assays or it is somewhat lesser with expert assay as no, the specificity is actually more with the expert assay as compared to the expert ultra. So expert ultra, it shows higher sensitivity but a bit lower specificity. Then we also compare the performance of expert ultra and versus the expert in TB meningitis cases using cerebrospinal fluids, and in the top lane the sensitivity was 76.5% in the ultra, while it is 53.6% with the expert, though the specificity remained high of 100% each in both the assays. Coming to the osteoarticular TB and taking the first specimen, the sensitivity was 90.9% and specificity of 97% with the ultra, while it decreases the sensitivity to 78.8 with expert, while the specificity increases to 100%. And similarly in ocular TB, the sensitivity is quite low in expert, that is 16% compared to 50% with ultra. We also compared GeneXpert Ultra test with several molecular tests besides GeneXpert, which include TrueNAT, which includes real-time PCRs, and then the multiplex PCR and so on. So in the first lane, we showed that the fresh, the frozen lymph node biopsies, they were subjected to ultra and abort real-time PCR as a commercial test, which demonstrated higher sensitivity, which was more with the ultra 57.1 versus 52.3 with the real time, while the specificity was also higher with the ultra 100 versus 92.5%. with the abort real-time PCR for detecting TB lymphadenitis patients. So in the third lane, the CSF samples were subjected to ultra and multiplex PCR targeting MPT64, IS610 and PSTS1, where multiplex PCR, that is in-house, revealed a higher sensitivity of 88% compared to 70.7% with ultra against composite reference standard. However, both the assay exhibit higher specificity of 100%. Coming to the meningitis cases, the sensitivity was higher with the ultra, 88% compared to 67%, though specificity was not mentioned. Then again, coming to the ocular TB, the sensitivity was 50% with ultra compared to the multiplex PCR, where the sensitivity was more, 72%, while both the assays showed high specificity of 100% each against composite reference standard, where composite reference standard means it is a combination of smear, culture, imaging, then histopathology, cytology in response to ATT, as well as the biochemical test. Any test positive with one or more parameters is considered to be positive with this composite reference standard. However, there is no single report available to diagnose exclusive peritoneal TB, abdominal TB, and cutaneous TB by ultra, but few studies evaluated ultra in total EPTB specimen, including acidic fluids and skin abscesses and biopsies. Pers, Visco et al. Showed that 1 out of 3 acidic fluid was positive by ultra, thus yielding 33% sensitivity, whereas sensitivity of 50 and 100% were attained with skin abscess and skin biopsies respectively against culture. Concurrently, Pinata et al. Documented a sensitivity of 66.7 and 100% specificity with acidic fluids against culture, while only one skin biopsy was analyzed and that was found to be negative, resulting into 0% sensitivity. While assessing the different extrapulmonary specimen comprising pleural fluid, FNA tissues, cerebrospinal fluid and peritoneal fluids, none of the peritoneal fluid was positive by ultra or expert, as well as MGIT 960 culture, that's showing the 0% sensitivity. So overall, it is quite difficult to evaluate the true performance of expert ultra for peritoneal TB and abdominal TB or cutaneous TB owing to a limited number of samples being analyzed. We also compared our ultra with other molecular tests. We summarize here the performance of ultra. It's a fully nested real-time PCR targeting IS6110, IS1081, RPOB gene for identification of MTB and RIF resistance. It detects RIF resistance by the melt curve analysis of the sloppy molecular beacons. It has a large chamber of 50 microliter for DNA amplification compared to expert, and additional trace call category. In addition to high, medium, low and very low categories present in expert. The limit of detection for MTB is 11.8 to 15.6 CFU per ml in spike sputum sample, which is 8 times higher, compared to the expert. So coming to the next slide, we have a molecular test of TrueNAT. TrueNAT, is developed in India by the Mole Bio Lab, Goa, and in collaboration with Find Agency. It's a battery-based test, which can be used in peripheral settings. It includes, TrueNAT and TrueNAT Plus as well as TrueNAT RIF for determining the rifampicin resistance. The plus point is this is chip-based real-time PCR that detects MTB within 1 hour. After a positive result only, we add on chip for detecting RIF resistance. So it's comparatively, less costly compared to the GeneXpert or GeneXpert Ultra. It also detects rifampicin resistance by melt curve analysis. It was endorsed by the WHO in 2020. It's portable and the turnaround time is just 1 to 2 hours. Then we come to the line probe assay. This is isothermal nucleic acid amplification test, which uses 2 or 3 set of specific primers to identify 8 different region of MTB specific DNA sequence. It was also recommended by WHO in 2016 as an alternative to smear microscopy to diagnose pulmonary TB, although it is also being used for extrapulmonary TB diagnosis. It can be examined by gel electrophoresis or visual detection method using cybergreen, hydroxynaphtol blue, calcine, and so on, where visual detection is comparatively easier and more cost effective. LAMP can be translated into a point of care test since it is simpler, quicker, and inexpensive method compared with PCR and nested PCR. However, it requires a complex primer designing system that constrains the target site selection, thus it has a high risk of carryover contamination which may lead to false positive tests. Then we have the line probe assays, which are reverse hybridization technique where the sample after DNA extraction PCR, they are subjected to hybridization with complementary probes are used on the strips, membrane strip. The WHO endorsed the use of first line probe assay genotype MTB-DR in 2008. First line LPA line probe assay are used to detect TB, including extrapulmonary TB and RIF resistance, INH resistance for INA gene, CAT gene, and so on. The second line LPA assay are highly sensitive that detect mutations associated with the injectable drug, the second line injectable drug. However, LPA cannot detect synonym and non-synonym mutations, and the mutations which are not covered by the test region and is less infective, less efficient in detecting heteroresistance. The turnaround time is 72 hours. Then we have whole genome sequence. It has emerged as a modern test to detect mutation associated with drug resistance, but has the potential to identify new drug resistant mutation. It reveals the exact type of MTB affecting the patient, including the complete drug resistance profile. The 3 classes of sequences are used: the first generation sequences, the second generation sequence, and the third generation sequence, that is Oxford Nanopore technologies. The main limitation is high cost of the equipment, the requirement for technical training, and the need for expert guidance for the clinical interpretation of the whole genome sequence data. Turnaround time is 24 to 48 hours. Then we have commercial real-time PCR. They are also being used, and the turnaround time is 5 hours, and which include, Amplicon, Cobas, Roche, Lightcycler, and Abbott real-time PCR. Additional testing for RIF resistance, IH resistance can also be performed, and Abbott real-time PCR and fluorotype MTB DR test target RPOB gene, CAT gene, INHA gene, and so on. The last but not the least is the immuno-PCR assay, which comprises the versatility of ELISA with the exponential amplification of PCR and real time, which exhibit at least 10 to the 2 to 10 to the 4-fold higher sensitivity compared to ELISA. Immuno-PCR or real-time immuno-PCR can detect array of MTB biomarkers which are protein or lipid in nature. We have detected antigen like AG85B, MPT64, God factor, etc. with this technique. The turnaround time is about 1 day. The other variants include nanopore-based immuno-PCR, real-time PCR assay, which reduce the background signal and result into enhanced diagnostic accuracy. Concluding the whole talk, Ultra exhibit an enhanced chemistry that uses a fully nested real-time PCR among various EPTB types, lymphadenitis, pleurisy, and meningitis. Expert Ultra revealed variable sensitivity against culture or composite reference standard, but limited information is available on other EPTB type. Expert Ultra showed an improved sensitivity compared with Expert, which is due to inclusion of trace call, though the trace call should be interpreted carefully. Then Ultra reveals a bit lower specificity than Expert, where some false positive is due to previous TB history, ATT follow-up, or non-viable baseline clinical specimen. Fewer false positive, negative, RIF-resistant results are obtained with Ultra as compared to Expert. We also described the other molecular tests in this study, and which include first line and second line LPAs, 2NAT, 2NAT plus, whole genome sequence, and the commercial real-time PCRs and the immuno-PCR, nano-based PCRs. Ultra detect RIF-R and trace call reveals, RIF indeterminate results, and which is bad. To overcome this, line probe assay can be utilized to detect drug resistance to other drugs in suspected MDR TB cases after obtaining a positive Expert Ultra. Like Expert Ultra, TrueNAT test detects MTB and RIF resistance, but is comparatively less costly and battery operated, thus it can be used in the remote area. Contrarily, whole genome sequence can detect a variety of genes associated with the mutation. However, it is quite expensive, especially for the resource limited setting. Overall, the usage of Ultra has improved the diagnosis of extrapulmonary TB, though the specificity need further improvement. About the future plan, though Ultra is a major advancement over Expert, it still has not replaced the latter. In many labs of high TB burden countries, including India, we expect that Ultra would replace the Expert in the next few years and improve the diagnostic outcome of EPTB cases. Even if Ultra exhibit improved sensitivity compared with Expert, specificity is lower in most of the studies, and it is difficult to interpret the trace call. Hence, Ultra needs to be further optimized to improve the specificity, and the trace call should be interpreted in more defined ways. The GeneXpert platform for Ultra requires a stable power supply and annual recalibration of the instrument. Designing a battery-operated device could be thus designed that would improve the extrapulmonary tuberculosis in all the health settings. These are the references used in these studies. Thank you for your attention. Thank you very much.